This is The Rounds Table.
Welcome back, Rounds Table listeners. This is John Fralick, one of your hosts. Today, we're going to do a solo episode. This is Rituximab versus conventional therapy for remission induction in Eosinophilic Granulomatosis with Polyangiitis, a randomized controlled trial. This was published in the Annals of Internal Medicine, July 2025 by Terrier et al. So what was the research question here? They wanted to know, how does rituximab compare with conventional therapy for the induction of remission in patients with EGPA? So why is this important? Well, randomized controlled trial evidence is hard to come by for conditions like EGPA due to the rare nature of the disease. As a quick reminder, EGPA is a small vessel vasculitis associated with asthma and elevated eosinophils. Multiple other organs can be involved, including renal involvement and peripheral neuropathy. More commonly, those are seen in patients with ANCA positivity, as well as cardiac involvement. In particular, that's in patients with ANCA negative disease. There is randomized controlled trial evidence showing that rituximab is non-inferior to cyclophosphamide in inducing remissions in patients with granulomatosis with polyangiitis, as well as in those who have microscopic polyangiitis. But patients with EGPA were not included in the trials. There is some observational data to suggest that rituximab may be effective for EGPA, and so this group set out to study if rituximab plus steroids would be superior to conventional treatment for induction of remission. So what was the study design? This was a phase 3 multi-center randomized controlled double-blind superiority trial conducted in France. For the patient population, it was adults 18 and older diagnosed with EGPA regardless of ANCA status, either as a new diagnosis or relapsing disease at the time of screening. Patients were excluded if they received rituximab in the prior 12 months. For the intervention, patients were randomized 1-to-1 to either rituximab or conventional therapy. Patients were stratified based on new onset versus relapsing disease severity, as well as ANCA status. Disease severity was defined by the 5-factor score, which takes into account the degree of proteinuria, creatinine elevation, and whether there is GI, cardio, or CNS involvement. Higher the score, worse the prognosis. In the rituximab group, all patients were on steroids with a predefined tapering schedule. Rituximab was then given as 1 gram on day 1 and day 15 as induction therapy, regardless of the patient's 5-factor score. Those with a 5-factor score of 0 did not receive any maintenance therapy, which is standard of care for these patients. If the 5-factor score was 1 or greater, then they were given placebo cyclophosphamide and placebo uromethexin, as well as maintenance azathioprine dosed at 2 milligrams per kilogram on day 180. Patients in the conventional strategy group received rituximab placebo on day 1 and day 15. Those with a 5-factor score of 0 did not get any maintenance therapy. Those with a score of 1 or greater were then given IV pulses of cyclophosphamide 9 times over the course of 155 days in combination with uromethexin. Those with a score of 1 or more also got maintenance azathioprine started on day 180. Now for the primary endpoint, this was the percentage of patients who achieved remission. This was defined as the absence of disease activity attributable to EGPA corresponding to a Birmingham Vasculitis Activity Score, BVAS, of 0 at a prednisone dose of 7.5 milligrams per day or less at 180 days after randomization. For the secondary endpoints, this included things like whether or not a patient was still in remission at year 1, what the survival was, as well as a number of other secondary outcomes. This was an intention to treat analysis. So who was included? Well, from December 2016 to October 2019, 157 patients were screened, and ultimately 105 were enrolled and randomized. 97% of patients completed the study to 1 year. The average age was 58, 52% of patients were female, the majority, or 70%, had a new diagnosis, and 30% had relapsing of their disease. 60% had a 5-factor score of 0 corresponding to a more favorable prognosis. 56% were ANCA positive, 37% had cardiac involvement, 17% had renal involvement, and 75% had pulmonary involvement. So what did they find? Well, there were 33 patients, or 63.5% in the rituximab group, and 32 patients, or 60.4% in the conventional group, who had remission at 180 days. This corresponded to a relative risk of 1.05 with confidence intervals ranging from 0.78 to 1.42. For some of the pertinent secondary outcomes, there was no difference in recurrence at 12 months, there were similar rates of relapse between the two groups, and similar average prednisone dosing. Rates of serious adverse events were similar between the two groups, with infection being the most common. So what are some of the study limitations? Well, it was a smaller sample size, but we have to remind ourselves that this is a rare disease. As well, outcomes were at 6 months as well as far as 12 months, but whether or not there may be longer-term benefit with rituximab is unknown. As well, this trial was designed to detect if rituximab was superior to conventional therapy, and so we cannot use this trial to specifically comment on whether rituximab is non-inferior to conventional therapy. So what was the take-home message? Rituximab was not superior to conventional remission induction strategies in EGPA. Is this practice changing? Well, let's be honest, as an internist, I'm probably not going to be the one making a decision about definitive treatment for EGPA, but this research helps to confirm that in the short term, if non-severe disease, steroids are the standard of care, and in those with severe disease, cyclophosphamide is still standard. Well, that was just a quick one-off rapid-fire episode, but before we go, the good stuff. Over at medicinepods.com, we're featuring the I Am Pharmacy podcast. It's got really fascinating content that explores aspects of drug discovery and deprescribing. In the more recent episode that I heard, they interviewed Dr. Jerry Avorn. He's a professor of medicine and internist at Harvard. The interview is providing insight into drug pricing in the USA. It's a really interesting podcast. Check it out, medicinepods.com. Well, thanks a lot for listening. Talk to you next time. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X.